Thank you very much to the IEC for the opportunity to present at this symposium. I'm going to discuss novel systemic treatments in AD clinical trials and placebo responses. These are my funding disclosures. I'd like to acknowledge members of our team. Simon Danby leads our biomarker clinical trial lab. This is such an exciting time to be involved in AD clinical trials. Not only do we have many new therapies, biologics such as dupilumab, tralokinumab, anti-OX40, small molecules such as JAK1 inhibitors, abrocitinib, and many other therapies in development. But we also have biomarkers. And here's an example of an imaging biomarker taking a biopsy virtually through the skin. I was proud to be part of this paper from the IEC, Optimization of Placebo Use in Clinical Trials. This is such an important question. So, what about disease severity? If we include patients with milder disease in clinical trials that are designed for moderate to severe disease, this can artificially enrich the placebo response. Another major effect is topical corticosteroids. So the controversy probably reflects two opposing problems: strict and prolonged prohibition of topical steroids during clinical trials risks selecting against patients with severe AD because they drop out, they can't survive in the trial. And so this elevates the placebo response. The opposite also applies. If we use a lot of topical steroids in the clinical trial, this will also raise the placebo response. So how do we resolve this dilemma? Recent studies of lebrikizumab and tralokinumab, the phase 2 trials in moderate to severe AD patients where topical steroids were mandated, found much higher placebo responses than the dupilumab trials. However, when the phase 3 trials were conducted with tralokinumab, the placebo responses were less. So maybe this was a patient selection phenomena, more moderate patients in the phase 2 than the phase 3. There are multiple factors that affect the placebo response. So I'm going to compare two pediatric dupilumab trials and look at the placebo and the active dupilumab and compare the differences. So this is dupilumab 6 to 11 years, paper led by Amy Palla, and this allows topical corticosteroids. So let's look at the percentage change in EADV. Dupilumab 82%, placebo 49%. And then this is the adolescent trial. Topical steroids are not permitted, paper led by Eric Simpson. So let's look at percentage change in EASI here. For dupilumab, it's 65% and placebo 25%. The differences between the placebo and the dupilumab are not that different in the two trials. It's just the absolute values that differ. And this was the same in the adult dupilumab trials. If we go on to EASI 75, and here again we're looking at the age 6 to 11, and dupilumab is 70%, achieving EASI 75, placebo is 27%. So this is with TCS. And then if we then look at the adolescent paper, EASI 75 at week 16, no rescue TCS, dupilumab 41%, placebo 8.2%. So the difference between placebo and dupilumab with TCS or without TCS is virtually the same. It's just the magnitude of effect we see. So as the placebo response may be increased in patients with moderate versus severe disease, performing a subgroup analysis by disease severity could help us enormously in understanding the differential effect of the placebo in these different populations. And this is a very important way going forward to help reduce the effect of placebo response. Well, let's look at a real life patient in a biologic clinical trial. I saw them a couple of weeks ago. They're at week 12 in the biologic trial. You can see the picture of the child's legs on the left, erythrodermic, clearly on placebo. They're not going to survive in the trial unless they have rescue TCS. Unfortunately, in this trial, it was permitted. And in 1 week, the mother used 320 grams of a potent steroid, and you can see the dramatic clinical response. Other pictures showing exactly the same. So it is incredibly important to measure the quantity of rescue TCS as a secondary outcome in placebo-controlled clinical trials. This is something we've grappled with over many years, but we really need to renew our focus on this in future clinical trials. So in conclusion, concomitant use of TCS facilitates inclusion of more severely affected AD subjects, but raises the placebo response. This is so important. We have to include these severe patients. They desperately need these new therapies. However, on the other hand, long TCS washout periods and avoidance of TCS during trials selects for patients with milder disease and risks a higher placebo response. So severe AD would not be able to continue on placebo without TCS rescue. And it's therefore essential to have TCS rescue in these trials. As the placebo response may be increased in patients with moderate versus severe disease, performing a subgroup analysis is extremely important to try and delineate the effect of the placebo response. But what is the most important intervention to reduce the effect of placebo responses in AD systemic trials? This is the most important intervention. Another direct quote from our IEC placebo clinical trial paper. Selection of sites with recognized expertise in AD management and testing of therapeutics should be encouraged to ensure that the right patients, inclusion criteria, and assessments are implemented, as well as having dermatologists with substantial clinical and research experience in AD performing the clinical assessments. This is the most important intervention we can make to reduce the impact of placebo responses in AD clinical trials. Thank you very much for your attention.